Good morning, everyone. My name is Damon Johnson, and I'm the program manager for Georgia AIDS Education and Training Center. Today, we have a very dynamic discussion that will be led by Dr. Gregory Felzine, who's the Diplomat Internal Medicine and Infectious Disease Medical Advisor for the Georgia State Department of Public Health. He's a phenomenal partner, very experienced provider, and one of the most knowledgeable men that I know. I'm introducing him to some, and to others, you guys are familiar with him. But without further ado, we're going to pass the mic over to Dr. Felzine, and he'll lead us in this dynamic discussion today. Please be prepared to participate and evaluate us at the end of this session. There'll be a few polling questions, and if possible, we would like everyone's participation. So without further ado, we have Dr. Gregory Felzine.
uh, a significant number of individuals working together and collaborating in reaching these goals. So if we look first off at the learning objectives, and I know I see several individuals that are outside of Georgia, and we're going to give you a few tools to kind of look at in looking at data that is closer to home. So first, if we can go through a case, and we should see some polling information here on the screen, hopefully here in a second. So we have a 27-year-old female sent from the OBGYN clinic where she presented because she thought she was pregnant, and the pregnancy test was positive, and the OB was savvy enough to go ahead and get an HIV point-of-care test, which unfortunately was positive. The other screening tests were negative for other STIs. The HIV RNA, by the time you're seeing this client, is 1 million copies. CD4 count of 650. Genotype resistance test is pending. She's approximately 9 weeks pregnant. So which of the following medications should be included in her initial antiretroviral regimen while we're awaiting the genotype test? So we're going to start TDF-FTC as our backbone. So would you like to start A, Maraviroc, B, efavirenz, C, nevirapine, D, raltegravir, or E, Zerit? So go ahead and you can click on the right-hand side of your screen and submit your answer.
While they're answering, Dr. Felzine, would you please put your PowerPoint in presentation mode?
Yeah, I will right after this,
Okay.
and we'll switch on over because I'll probably have to switch back for the poll so I can see it. Perfect. And if we can go ahead and get the polling answers. And the results. So the majority of folks, we have no answer. We had a few brave souls, 5 people that did try to answer the question. And go ahead and answer. We don't know who you are, and even give it your best bet. So in this instance, and we'll kind of get to the punchline here in a bit, we want to avoid efavirenz and we want to avoid NNRTIs until we get genotype resistance testing back. And I'll give you some data that shows that. So really, in this instance, we do, of the choices, we want to start raltegravir. And not only do we want to start raltegravir with the TDF-FTC, we want to use twice-a-day dosing. So the 400 milligrams twice a day, not the HD that's out, the 600 milligrams, 2 tablets once a day, since that is not FDA approved currently in pregnancy, but we might be able to see those changes down the road as the guidelines change quite rapidly. I live in Georgia, and that's who I'm more intimate with. But I'm going to switch my screen here in a bit and show some folks some data that they can obtain because I see some folks from out of state. But keeping in mind that do reach out to your local and state health departments and public health to obtain that data because it's so important in that when you're asked to give a presentation at the local level, yes, it's interesting to see world data, national data, state data, but most of the folks that I speak to, you really want to personalize this. And if you can get it down to the county level, that's going to be one of the most important things. I'm going to show you a website where you're able to do that. Because in Georgia, a couple of things that we want to be cognizant of is knowing this data and knowing how individuals are interpreting this data. So even though on the right-hand side here, you can see that the rate per 100,000 for HIV is dropping. You can see 31.8 in 2016 dropping to 24.3 in 2018. We don't want legislators to look at this or the individuals that is holding the purse string to say, "Oh, we must be doing such a great job. We're gonna decrease your funding." When in fact, if we look at Georgia's rank, we've been number one in rates per 100,000 for 2016, 17, and 18. And the same type of thinking that when you look down at chlamydia, our national rank has gone from fifth, sixth, seventh. So we're heading in the right direction. But if you look at rates per 100,000, we've gone from 614, 631, 632. So even though our rank is going in the right direction, that our rates have remained stable in the 630s. The other reason to have this information is we started expedited partner therapy initially just for chlamydia, and we want to see if that has an effect on our rate per 100,000 moving forward. So hopefully in the next few years, we'll have some additional information on this. The other thing to keep in mind, and again, going back to my comment, when we're speaking to individuals, we want to personalize this. We want to bring this home because we still have individuals that believe that HIV and even other STIs is not an issue in their community. And I've given this presentation at the local level, and they've all stopped me and said, time out. I did not realize um, that this was a major epidemic here in the state of Georgia. So we want to bring attention to that. We also want to bring attention that, here in 2017, we had nearly 59,000 individuals living with HIV. And of those, 16,000 were living in Fulton County, so that's downtown Atlanta. And the reason why I bring that to attention is we have individuals in rural areas of Georgia that believe that, oh, if this is occurring in Georgia, it must be occurring in the Atlanta area only. But I do point out that no matter what district, and I have a map here to the right, that you live in, there are individuals living with and affected by HIV. So let me stop this for a second. So one of the things, if individuals have not seen this, is going to AIDS View, and this happens to say Atlanta, but you can click on the view the map and get this down to your zip code, which will also allow you not only to look at rates and numbers of individuals living with HIV, but will also allow you to compare social determinants in areas, looking at household income, education, etc. There's also a new AIDS View PrEP, pre-exposure prophylaxis, which I think also is going to allow folks to be able to access services a little more easily and look at PrEP uptake in some of the rural areas in their state. So if you haven't seen this, it is aidsview.org. And I think it's a really good tool to kind of look at and bring this home and personalize it to folks that you're are speaking to in your local area. The other thing to keep in mind is one of the hot topics that we have is telemedicine, telehealth, is really looking to see what your state offers. We have 159 counties in our state, and we have telehealth access in all of these counties and all of the health departments. So we want to make sure that we do have access, especially during COVID-19 when individuals are still social distancing. I know there's been a lot of reports of states opening up. Georgia's been one of those. But it's been very slow, and individuals continue to social distance, and not everybody has opened their doors, and it's not business as usual. And also making sure where we can access information. So here in Georgia, we did receive funding through the Georgia Care and Prevention in the United States Act, and we're able to link individuals. So if someone's having a screening program in their local area, one of the things we don't want them to do is just to say, oh, you were positive, go see your primary care provider on Monday. And we know because of continued stigma and discrimination, they're not going to do that. And we miss an opportunity to link individuals to care. And even if individuals test negative, we need to link them to preventative services, to pre-exposure prophylaxis. So we really want to think about that. We still have a few facilities in the state of Georgia that have opt-in testing, despite the CDC and the national guidelines supporting opt-out testing. So we want to make sure and just make sure that you're not making the assumption. If you're in an urban center and you're working with rural areas, don't make the assumption everyone's doing opt-out testing. Ask those questions. And here in Georgia, we have a law that says we merely just need to add some simple notification on opt-out language to an existing medical consent form. And I really stress that. We don't want individuals to really have a separate form for this, and because it doesn't matter what it is. It could be syphilis, it could be as simple as a complete metabolic panel. It doesn't matter what it is. Individuals see something as quote different, they're less apt to sign it, even though that is really standard of care. The other thing is just to remind folks, because we've had facilities in the state when we're having conversations to say, well, it's a very laborious process. We have to do this pre and post test counseling. I said, no, we don't need to do that anymore. It's been supported by the CDC and national guidelines that can really be a barrier and be counterproductive, but really just give some medically appropriate information of why you're doing testing. We do the same thing if I'm testing somebody for syphilis, or they come in and they have signs and symptoms of gonorrhea. I'm going to say, well, we also want to test you for syphilis, chlamydia, HIV. It all comes in a package, and making sure that we're treating these individuals appropriately. The other thing that's nice, in 2014, we did have a law signed by Governor Deal at the time to allow better health information exchange. And you might be in a state where it's very difficult to exchange HIV-related information. And Georgia was one of those states for several years, making it very challenging to share health care information for an individual. But this has really opened the doors and has allowed us to do better information exchange. So, one of the things we really want to think about, and we haven't really gotten to pregnancy yet, but we really want to set the stage and really think about this. We want to make sure that as screening initiatives are being ramped up, that we really want to get individuals into treatment as quickly as possible and on antiretroviral therapies for a couple of reasons. Really, if that individual is not being treated, there's increased harmful impact of ongoing HIV replication. We see that growing in the literature in the last several, even the last several weeks. But we also we want to prevent secondary transmission. And some of the initial data showed a 96% reduction. I'll show you some of the other studies that have come out. But in the same sense, we shouldn't be prescribing medications just to make us feel better. We want to make sure that that individual is willing and able to commit to therapy. And most of the folks I speak to are, but I still have individuals that come into my clinic that had used cocaine or shot up with something that morning, which legally I'm not able to talk about treatment at that time, except making sure they're safe, making sure that they're in a safe place, making sure they're not driving home and injuring other individuals on the road. So we want to make sure, and having another discussion, getting them back into care, making sure we're having those discussions and getting them on treatment as soon as possible. And really what that came from is the 052 study, treatment as prevention, and really was a public health benefit. And as we know, and we'll go ahead and hit the punchline, that undetectable equals an untransmittable. As long as somebody is taking their medications as prescribed, they're remaining undetectable. The other thing is if we can decrease the overall viral load um, in the community, we're going to decrease new diagnoses. And then, of course, with the START and Temprano studies, really discussed getting folks on treatment as soon as possible, regardless of their CD4 count and their viral load. We want to get folks on treatment so we can minimize long-term effects. Now, I will say here, there was some data that was presented in March at the conference on retroviruses and opportunistic infections, CROI, that did discuss a couple of things. One of the abstracts looked at if we compare individuals newly diagnosed with HIV at age 21 and look at their counterpart individuals that are not living with HIV, they have a near normal life expectancy. That gap is really shortening. It's down to 3 years. The issue becomes, and there's going to be hopefully more research and more data coming out, is the comorbidities. And that's at 20, that individual who's living with HIV, age 21, by 36, we're starting, or I mean, by age 34, we're starting to see comorbidities compared to the age of 50 of that individual who is not living with HIV. So there's a 16-year gap when we're looking at comorbidities. The other aspect, and of course, we're not going to go through each one of these medications line by line, but just to remind us, we do have a large number of HIV medications available to us. Of course, some of these are no longer being used due to multiple side effects that we saw in the past. Things like DDC, where we're seeing peripheral neuropathy, pancreatitis, these medications are no longer available to us. But the reason why I show this slide is we still have individuals that have the belief, and I've been caring for individuals living with and affected by HIV since 1992, of sending off providers for a 2-week course. They come back, they're the experts in the field. We could do that when we had 2 or 3 medications. Now we're working with a plethora of new medications, newer classes coming out here in the next few months, where we have to think about comorbidities, we have to think about drug-drug interactions, and we also have to think about the increasing number of fixed dose regimens, and either in single tablet regimens. And I speak to providers when I'm in the field. They say, "Oh, I've been doing this for 4 or 5 years." And you ask them, "Oh, well, you started them on one of these fixed dose combinations. Tell me what medications are in that." And they kind of hum and haw, and they're not able to tell me. And come to find out, they just selected one of these without really thinking about the medications that are in these single tablet regimens. And why I mention that is some of the boosters, cobicistat or ritonavir, have significant drug-drug interactions that we have to really think about, especially as people are aging and living longer with HIV. They are starting to develop comorbidities, and we really have to think about those drug-drug interactions and really think about a lot of times switching regimens because of that. So if we look at, and again, this is just for adult and adolescents, the most up-to-date guidelines, what should we be starting individuals who are living with HIV? And if you really look at the top of this, it's really switched over to um, integrase-based regimens. So you can see here that, of course, we don't want to just throw a dart at this top part of this chart and say, that's what we're going to pick. Of course, with Triumec has a bacavir, so we want an HLA-B 5701 test, and I'll stress that it's 5701, not the HLA 27. We're not thinking about things like ankylosing spondylitis, etc. And I mention that because some of the rural areas I practice in, I forget to contact the lab and say we want an HLA-B 5701, not a 2701, and they don't know what a 5701 is, and they run the wrong test. So we have to think about that. Again, back to the raltegravir at the top right, it's 1 pill twice a day. Or in the HD combination, it's 2 pills once a day. So be cognizant of that. So I've prescribed that to clients, and they come back with the TAF FTC bottle empty and the raltegravir bottle half empty, because they didn't understand they needed to take 2 pills out of the raltegravir bottle. So really doing that education and understanding. And then Dovato for naive patients hit the guidelines, was recently FDA approved, but we have to keep in mind a couple of things. And that's why we want experts in the field caring for folks with HIV, because with this 2-drug regimen works well, non-inferior in its tests, but we do not want to start it on individuals with viral loads above 500,000, which is great. I don't see a lot of those folks, 2 or 3 a year. We want to make sure a genotype is done and there's not an M184V, which causes resistance to the 3TC, because then we'd be giving monotherapy. And also, we want to make sure that individual does not have hepatitis B. Although 3-TC, which is lamivudine, treats hepatitis B, it is not recommended as monotherapy because of high rates of development of resistance. I've seen data 70 to 80% within 5 years. So we want to make sure that we're not undertreating somebody with hepatitis B. And I've had some folks say, well, we can just add entecavir to that. And I said, well, we could do that. And suddenly we're at a 2-pill once a day regimen. If somebody wants to be on a single tablet regimen, there's other options for folks that are co-infected um, with HIV and hepatitis B. So this gets back to that first question, and we have another case coming up, is we didn't have the genotype results back. And you can see that from individuals who are naive to care, we still have a growing number percentage that we're seeing resistance. And if it's an NNRTI, which you can see 15% of folks walking through the door, and half of those individuals, it's a K103N, which would then not allow us to use the efavirenz. So that's why that question in that situation was not correct. So we have to think about what's going on in our community and what type of resistance are we seeing. And when that individual comes in, to really do a contact evaluation, because many times they acquired HIV from somebody you're already taking care of. And a lot of times they're treatment experienced and they already have multi-drug resistance. And we don't want to give an individual medication that they may have acquired their mutations and their resistance patterns. So we really want to think about that. So let's get into pregnancy. That's kind of was a quick overview of HIV and kind of where we're at. And if we look at pregnancy, and I always ask this question, who should we doing preconception counseling with? And the most common answer I get is women of childbearing capacity. And I would argue, and I would challenge everybody on this call, is talk to everybody that walks in your door. I have plenty of young men who have sex with men, and I ask them about family planning. And they'll say, yes, I have a male partner, we're monogamous, but we know this friend from high school. She wants to have a child. She wants to have a child with us. How do you plan on doing that? Are you going to do sperm washing, which is nearly 100%, which minimizes HIV transmission, but very expensive? And is not covered by insurance companies that I have found. Does that individual, are they aware of somebody's HIV? So we want to make sure that the individual living with HIV is on antiretroviral therapies. You know, we talked about U equals U. The individual may not know about their HIV status. So the young woman needs to come in. We need to have that discussion. They may want to go on pre-exposure prophylaxis, and there's growing data to give PrEP during pregnancy. So we want to think about that process. Are there other STIs that we want to think about, other comorbidities? We talked about hepatitis B because every time a baby is born with HIV, that is a sentinel event. And a couple of years ago, we knocked on the door of an OB group, actually two that year, and both were just shocked. Quote, I don't take care of those patients, unquote. And we're like, well, we need to do a little education. And they were shocked about the number of STIs that we see in Georgia. I showed you that's why I showed you that data to really look at that. And really, this is an old article from the OB literature, but just to kind of show us, if we look at healthcare providers here on the right doing preconception counseling, not even 20% of the time. So we really want to think about that and bring that into the discussion, whether that be the nurse educator that's having that conversation, whoever's doing your education during the visit can kind of take on that role. The other thing to think about is the initial assessment can be quite extensive. And when we look at this, people will say, well, this will cost a couple of $1,000s to do this lab work. And I always ask folks, I say, what is your role in the care of this individual? If you're the OB and your role is screening, well, all you need to do is think about a point of care test, and we have plenty of great point of care tests to evaluate individuals. If they're positive, do some basic education. meaning that, confirmatory testing needs to be done. We're going to link you to an HIV specialist today. Hopefully they can see you within the next day or two, depending on their system. They're going to go ahead and get additional lab work. They're going to come talk to you and really encourage them a couple of things. So if we think about this in the OB world is, one, you're not going to die of this. We want you to get into care, and we're going to do everything possible so your baby is not born with HIV. And I'm going to show you that data. So it all depends on where you are and what your role is. You may just be somebody that's screening and then referring and knowing who to refer to. The other aspect of this is we're going to talk a little bit about immunizations is not making assumptions. Who is on your team? I don't get it as often, but still a couple of times a year I do get that phone call. Um, the young woman is in the delivery suite. She is crowning. She's HIV positive. What do we do? And I think, well, we really needed to think about this before the situation occurred. Who is on your team? Do you have the medications available in the pharmacy? Is she on ARVs? Do you know their last viral load? When we think about immunizations, I was doing a chart review at a clinic and I had to just shake my head because we had records from everybody and I found it very interesting. The HIV clinic reported immunizations were being done by the OB. The OB was reporting it was being done by the HIV clinic, and the family practitioner was saying it was being done by one of the other two clinics. And unfortunately, the client did not receive standard immunizations during her pregnancy. Because as we know, if you're pregnant every year, you need a Tdap every year. That was changed in the guidelines a few years ago. But we also want to assess. We want to assess their hepatitis A and B status, and if need be, immunize. Are they hepatitis C positive? We don't have vaccines for hep C right now, but we want to start the discussion. And I've had some providers say, "Oh, well, we'll worry about your hepatitis C after you deliver," and then nothing happens. That conversation is forgotten. So we really want to think about this process. Um, so we have another case. A poll will come up here in a second. So we have a 32-year-old pregnant woman is being seen for her first prenatal visit. She's healthy, asymptomatic, been married for 4 years, states she is monogamous anyways. She has never been diagnosed with an STI. Pap smears have always been normal. She lives in a state that requires syphilis screening at the time of delivery. But in addition to mandatory screening at the time of delivery, which of the following syphilis screening strategies for the patient is most consistent with CDC recommendations? And again, go ahead and guess if even if you're not a prescribing provider, you're still part of this process and doing education. So is it A, no additional screening needs to be done? Screening at the first prenatal visit? Screening only if symptomatic, or screening only if risk is identified? So go ahead and vote, and then we'll get the answers here in a moment. And it goes back to, again, we have folks that are on the call, not from Georgia. It goes back to know your state law. And really understand what that law means. And we're gonna answer that as far as Georgia goes with this question. Of course, what are the CDC guidelines and what is your state doing? And having those conversations with the staff and educating them, and then having those conversations with the clients you serve. So if we could go ahead and close the poll and put the results up. And since the poll is closed, I'll go ahead and have the discussion here. We're going to see the results here in a moment. Is a lot of folks will always say, well, especially here in Georgia, and I've had this conversation in the Southeast, um, what the mandatory is. Again, we have a lot of no answers. So go ahead and answer. I mean, B is correct. And really, it's at the first prenatal visit. And we've had some folks say, well, it's during the first and third trimester. So no, that's not entirely correct. Because what happens is if we send that out as the message, individuals will say, well, I didn't do any testing because they came to me during their first prenatal visit during the second trimester. So I was told it's first or third trimester, so I waited to the third trimester. I said, no, we shouldn't really do that. When they enter into care, um, during the third trimester and usually at week 28. And why do we say that? We say that because it allows us time to go ahead and get the individual treated before they deliver. So we're minimizing the risk of congenital syphilis, which we don't want that to occur. Um, and then in our state, we have some additional things that we'll talk about here real quick. In our state, what we have as far as the law goes, and is we do HIV and syphilis testing again when they enter into care and the third trimester, and more often depending on exposures. And some people will ask, well, what about the 28-week mark for HIV? What's the magic with that? And we say, well, the magic with that is, of course, we're doing it for the syphilis, is we don't want to do tests at two different times. Go ahead and draw the HIV test or whatever test that we're drawing on that day, just so we can have it done. And when we speak to the client, when all of their lab tests are back, we can have that discussion. And this is just to remind us the CDC had released this information not too long ago, really show we're at the highest case rates that we've ever seen of sexually transmitted infections. So I showed you the data from Georgia, the ranking that we're at and the rates we're at. It's out there. So we don't want to make assumptions. I have individuals that come in with PhDs, some folks that come in with fourth grade education. We have the same discussions. Because I hear all kind of stories, and we don't want to make an assumption. Oh, somebody's been married for 20 years, and suddenly they have gonorrhea. We want to have those conversations and openly in a non-stigmatizing, non-judgmental way, and making sure that individual is being treated, their contacts are being treated, and that we're be able to educate folks. And again, know your data. Um, Again, we don't want individuals being born with syphilis because we some of the data I looked at last, 40% of individuals have poor outcomes, either developmental delays, stillbirth, death soon after delivery. So we want to think about this. And I'm going to show you two sets of data. Here's 2017, 23 reported cases in Georgia, and then in 18, it's gone up to 31. And the number one reason was no third trimester testing. So again, that's why we have the law. We want to educate folks. Again, no prenatal care. Is there issues with access, getting individuals into care to have these discussions and making sure they have appropriate access? And those are issues we think about. Georgia's not unique. You look across the country in rural areas, are there high-risk OBs available? Are they having these discussions? Is there a belief that STIs are not affecting their rural local communities? So we want to think about that. The other thing we want to think about is a lot of times when I talk to providers is not making the assumption that they understand where the epidemic is, because a lot of times they'll say, oh, well, HIV, that's young African American men who have sex with men. I don't take care of that population. I do a women's health clinic. And I say, well, HIV is not specific to a certain race. It doesn't care how much money you've got in the bank. It doesn't care where you live. We have to change our thinking and really think about exposure. And women are still acquiring HIV. So this is Georgia specific data. And again, I challenge you to go ahead and reach out to your health department or public health to say, hey, what is our data? Not just state data, but what's our local data? What does that look like? Um, and of course, use the AIDS view. You can put zip codes in there and really good at get rates down to the county level of what's going on in your area. So we really want to think about that. And the other reason why it's so important, again, this is 2006 data at a Lancet, but it still holds true. And we want to think about if individuals are acquiring HIV during their third trimester, there is a high rate of mother to child transmission. And that's what we're trying to prevent. So hopefully we can do a better job at prenatal care. We can do better counseling before an individual is pregnant and really think about um, what are their exposures? What risks are we thinking about? And really having those questions and taking a sexual history. And it really should be part um, of and really a normal aspect of when you're talking to somebody. We don't want individuals to think that you're just checking off boxes or preferencing and saying, oh, we're going to take a sexual history now. You shouldn't be offended by this. It should just be basic flow conversation. And that's how I like to take a history, where I might be talking about social history or family history, and there's a natural point in the conversation to really talk about a sexual history during that point. The other thing to notice, and this is Georgia data again, is there's been a switch from where we were seeing individuals with mother to child transmission with HIV in the more urban centers, like you can see here, Atlanta metropolitan statistical area, to a shift where women living with HIV are wanting to deliver um, where they live. They don't want to drive into the urban center. It might be too far away. They may not be able to get there. And what we're seeing is a shift in mother to child transmission more in the rural areas. So we have to keep that in mind. So we have another case. We have a 30-year-old woman living with HIV taking tenofovir, emtricitabine, efavirenz with a routine labs 1 month ago. CD4 count 905. Viral load is undetectable, missed her period, and did a home pregnancy test, which was positive. She came in. The pregnancy was confirmed by her primary care provider. Estimated she was in her first trimester. Um, the client intends to continue the pregnancy. So, what do we want to do with her antiretroviral regimen? Stop the ARVs until the second trimester? Stop the ARVs until labor? Continue the current regimen? Change the efavirenz to atazanavir ritonavir. Change the tenofovir emtricitabine to zidovudine lamivudine. So go ahead and vote. And again, it's okay to guess. We don't know who you are. We can't take your answers and link them back to you. So if we can go ahead and close the poll. And since it's closed, I'll say a couple of things. Those of us who have been doing HIV for a long period of time, and that's good. The majority of folks wanted to continue therapy. Um, when efavirenz first came out, there was a concern about the possibility of neurological defects, and really the data didn't get teased out um, in that there was a greater effect. And what the guidelines say here more recently, and have been some updates March and April of this year, that we really want to continue this regimen. With the efavirenz for a couple of reasons. One, we're not seeing an increased rate of neurological defects, and two, um, what the expert panel really discussed was is this individual is virally suppressed. They're adherent on the regimen that they're on. Therefore, changing might add additional adverse events. Suddenly, they may not be virally suppressed, and we really want this individual to remain virally suppressed throughout her pregnancy. So we'll get in a little bit of data that, and some of that comes from Ireland, which has been some fantastic data to kind of look at, and we'll get to that here in a bit. But everybody who comes in, they're pregnant, we want to continue their ARVs unless they're contraindicated, and I'll show you some data on that, or at least be offered ARVs. We don't want to manipulate or twist somebody's arm, but we really want to have an open discussion of why somebody needs to be on antiretroviral therapy throughout their pregnancy. And some of the key takeaways from some older data that taking ARTs for 24 weeks or more, ART initiation prior to 28 weeks gestation, because the old guidelines did talk about, this was 20 years ago, stopping their ARVs until the second trimester when organogenesis is passed. These type of things. This is not standard of care. And typically, when someone comes in and you're diagnosing them with pregnancy, organogenesis has already occurred. So we want to think about that. We want them to be virally suppressed throughout and at the time of delivery, and we want prophylaxis, which we're going to talk about. And be kind of the pre-ART era, mother to child transmission was as high as 30%. And some UK data has shown it's nearly 0% mother to child transmission if we do everything correctly. And we'll talk about that in a little bit more detail, what that is. So that individual that walks through the door, we don't have resistance testing. That was one of those first questions where that was the first question where raltegravir was the right answer. We still want to check resistance testing. We want to see if there's any mutations. And if we're going to start therapy, which I'd recommend as long as the individual is willing and able and ready to start, we can use a protease inhibitor or an integrase inhibitor. So we don't want to use NNRTIs like efavirenz or rilpivirine until we have further information. And if they're newly starting or we're changing a regimen, we want close follow-up. We don't want to just have them come back in 3 months and let's see how you are. There is some language in the current guidelines. Somebody who has, let's say, been undetectable for the last 3 years, they always pick up their medications on time. They're always undetectable. You can see them every 3 months. But I would argue in my patient population, I take care of folks that are very unstable, have a lot of issues around social determinants where they might within a week be having unstable housing. They might be housed and then all of a sudden unstable housing. Um, so I like to have some kind of contact at least every 30 days, maybe not with the physician, but at least with the case manager, nurse educator, the navigator, whoever you have in your system. And when you're going to protease inhibitors, you can get some hyperglycemia. It's not diabetes, but elevated glucose. And really go back to that team approach. What I find is there's a wonderful paper that came out a few years ago about the broken arm syndrome, meaning that I have HIV, I go to the emergency room with a broken arm, and they don't treat my broken arm because they relate it back to my HIV. They tell me I've got AIDS. It's because of my medications, and go back to my HIV doctor, and my broken arm doesn't get fixed. So we want to have this conversation because so often something will happen, labs will change, that provider doesn't pick up the phone, doesn't talk to you as the HIV specialist. They just tell them, stop your HIV meds, go back to your HIV provider, and they'll tell you what to do. And that's not the right answer. Now, saying that, if someone obviously has a severe reaction to a new medication, Steven Johnson, toxic epidermal necrolysis, obviously we're going to stop the medications. Those people are going to be hospitalized, and we're going to make other recommendations. So here are the up-to-date guidelines. And if you look at this, really in the preferred, zidovudine 3-TC Camivir has been moved down to an alternate because of the side effects, bone marrow suppression, etc. with zidovudine. The Kaletra, lopinavir, ritonavir, which if you're going to give, it's 2 pills twice a day. You can't do the 4 pills once a day. It has to be 2 pills twice a day, with an increase to 3 pills twice a day in the 3rd trimester. That's been moved down because of the hyperemesis and the side effects. But you have to keep in mind, again, we can't just throw a dart at this. If we're going to use atazanavir as a protease inhibitor, a couple of things. You get hyperbilirubinemia associated with it. It does not affect the unborn child. But it can make people worry when you start seeing an elevated bilirubin. The other reason why it makes it complicated is sometimes I can't get the higher doses. So it's 300 milligrams with 100 milligrams of ritonavir, but in 2nd and definitely 3rd trimester, it needs to be increased to 400 milligrams, and sometimes I can't get that pushed through the insurance company quick enough. Darunavir needs to be twice a day, so we don't want to use medications like Prescobix, which is darunavir cobicistat, and I'll talk a little bit more about this. Raltegravir, again, twice a day. Dolutegravir, which Triumec has dolutegravir in it, are all preferred agents. Now, the cobicistat containing agents dropped from insufficient data to not recommended because there were viral breakthroughs, especially in the 3rd trimester. And some people will argue, well, they're already on Gemvoya, I want to continue it. And I said, well, yeah, I've had some clients where the client said, I'm not changing my meds. And what the guidelines say is to just monitor their viral load more closely. And it'll say at least once a month, you want to follow that viral load. And if it starts to go up, we need to make some changes with that. And I've luckily, knock on wood, a couple of folks that I've watched with Gemvoya have done well. Their viral load didn't increase during the 3rd trimester. We had lots of conversations, and we did well with that. I have this as a handout, so anybody who's interested is a handout. Unfortunately, I could not get it approved through our state system and for this talk. But let me know at the end. I'll give you my email, and please let me know, and I'll shoot you that that handout with all of this information. And of course, the dual therapy, Dovato and Juluca, have not been FDA approved in pregnancy. So here we have another case. 19-year-old female presents to her GYN for routine care. She reports no prior illnesses, has never been tested for HIV. Pregnancy test is positive, ultrasound normal, everything looks great at 10 weeks. CD4 count 490, viral load 200,000. Genotype we have on this time, pan-sensitive. The rest of her labs are normal, and the OB says, hey, I need some assistance. So elective C-section regardless of viral load on antiretroviral therapy. Single dose nevirapine at time of delivery for mother and single dose for infant within 2 hours. Are we going to use lopinavir, ritonavir, tenofovir, emtricitabine to start immediately? Or are we going to do dolutegravir with tenofovir, emtricitabine immediately? So go ahead and vote. And let's go ahead and close the poll. So the question really asks a couple of things. We still have some providers, 2020, OB providers that believe HIV plus pregnancy equals C-section. We're gonna show some data with that. And we still have the issue of dolutegravir and neural tube defects. So what is that going to look like? So we have a good spread with this. So let's get into the data, and the answer was actually D. We want to go ahead and start dolutegravir on this patient, even though she's even in her first trimester. So those two folks that that voted that are up to date on the literature. So wonderful. So let's get into some of that data. And I know we're going to be short on time here in a minute, but I don't want to shortchange and just fly through this data. But let's talk about a couple of things. So the first thing we want to talk about is if we look at baseline neural tube defects across the board in the United States, it's 0.07. And early in the study that came out of Botswana, their neural tube defects were as high as 0.96%. So with that being significant, the FDA added asked that a black box warning be added to this medication during pregnancy. But as the data teased out, the first 4 women that had children born with neural tube defects, there were nutritional issues. So they were not taking folic acid, which we know is so important to minimize neural tube defects. And you can see the data here that if individuals were given dolutegravir later in pregnancy, there were no issues whatsoever. So April of this year, so just last month, the committee got together, released new guidelines, and said the panel recommends continuation of dolutegravir. The risk of neural tube defects is small, and rapid, durable viral load suppression is so important. And if an individual is already on dolutegravir, the recommendation is to talk to mother, but continue dolutegravir through the pregnancy. And if we look at the impact 2010 or 2010 results that preliminary results that were released in CROI in March, they looked at this data a little bit more closely. They had 3 arms looking at dolutegravir with TAF, dolutegravir with TDF, or a efavirenz-based regimen, which is still the most common regimen given worldwide. And really what they found with this data is they looked at 643 women, and I'm just going to look at 2 things. If you look at the results of all 3, 98% of the folks who received dolutegravir were virally suppressed at delivery versus 91 in efavirenz. So they found it was more effective. And if you looked at outcomes, it was the dolutegravir TAF. So as you saw in the current DHHS guidelines, TAF was listed as insufficient data. That if we're going to use tenofovir, it needs to be TDF. That would be preferred. So in this data, they showed that TAF with dolutegravir had the fewest adverse outcomes versus the 33% who are on the other 2 arms, and that preterm labor, low birth weight, and stillbirth were the most common adverse events. And through this study, there were no neural tube defects. So I think that's so important. I think that also kind of pushed folks um, to say, okay, maybe TAF, we should be moving it up to prefer dolutegravir. We really need to think about that in these regimens. So the folks that said C-section, we should only be doing C-section if individuals are presenting late in pregnancy acute infection late in pregnancy, otherwise normal vaginal delivery. And the Ireland studies really had teased this out. So if somebody's coming in with a viral load over 1,000, again, they're late in pregnancy before they start ARVs, we really need to think about C-section. And at that point, we need to remind our OB counterparts that it's at 38 weeks. And as an HIV expert in the field, I will put that in my notes. This individual, from an HIV standpoint, can proceed with normal vaginal delivery. Now, I may get a note back from the OB saying, oh, "Okay, great, but we need to do a C-section for other reasons, and we're going to go ahead and do that at 39 weeks." I said, "Okay." But there needs to be other reasons. What I don't want to see, especially in my stable clients, stable meaning virally suppressed from, prior to pregnancy, during pregnancy, oh, they have HIV, I need to do a C-section. That is not standard of care. So again, it goes back to that team approach and making sure that we're not inappropriately doing a C-section on somebody who can safely have a normal vaginal delivery. And this is the Ireland study that really showed that those individuals, again, everything went right. This is not the person who showed up late diagnosis in pregnancy, viral load above 1,000 late in pregnancy. This isn't that population. This is someone who is virally suppressed, adherent throughout their care. Those individuals can have a planned vaginal delivery as long as there's not any other OB indications for a C-section. And this data went out to 2015. I didn't show it here. Really showed that in Ireland there was an increased number of normal vaginal deliveries and no transmissions of HIV. Big changes. So we're no longer doing the 6 weeks of zidovudine. It's 4 weeks if everything went right. 4 milligrams per kilogram Q12 hours for 4 weeks. Everything went right. Client was on ARVs, remained virally suppressed, no lapses in care, et cetera, et cetera. They can do 4 weeks, and they need to complete the entire 4 weeks of zidovudine. Otherwise, what the new guidelines are talking about is a 3-drug regimen, either zidovudine 3-TC nevirapine or um, zidovudine 3-TC and raltegravir for 6 weeks. We want mother not to be breastfeeding. It's not recommended in the United States. If we were in sub-Saharan Africa, that would be a different story. The World Health Organization has clear guidance for breastfeeding for individuals who are virally suppressed. Um, but in this country, we have alternative feedings, and that's what the current guidelines are supporting. So 3-drug regimens is important for that population that does not fall into that category where everything was done correctly. Now, there is still some conversation in the guidelines that talks about 2-drug regimens, but I would really recommend using the 3-drug regimens as you see here. The next slide, I'm not going to go over in detail, but you will have these slides at your access of what the doses are for these medications. The other thing to talk about is newborn screening, and I get a lot of errors and a lot of questions with this, and I'll have somebody say, well, I stopped the zidovudine because in the hospital before they were released, a nucleic acid amplification test was negative, so they don't need it. And I said, no, 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 that's not what the guidelines say. For me to say baby is positive, I need to have 2 positive tests. So an indeterminate does not mean baby has HIV. So if everything went right, we're giving 4 weeks of zidovudine to baby. We're doing the nucleic amplification test at 2 to 3 weeks, 4 to 8 weeks, 4 to 6 weeks. Most hospitals I have found they'll go ahead and do the test at birth. That's fine. I'm not going to fault folks for doing that, but make sure we have the follow-up. Then we want additional testing if that woman is coming in higher risk, was not getting treatment throughout her pregnancy. And a lot of experts, including myself, that person that comes in, maybe they're diagnosed late in pregnancy, maybe they did or didn't get on ARVs. At 18 to 24 months, I'm going to do an antibody on baby. So just keep that in mind. I'm going to skip that for now. And really think about what your hospital is doing. Because I've had some of the facilities, well, they'll not continue the antiretroviral therapy while they're hospitalized. Make sure mom knows to take her medications, because a lot of patients believe, oh, the hospital has every medication under the sun. I said, no, they don't carry these medications. You need to take them, Make sure you take the medications while you're there. And if there is an indication for IV AZT at the time of delivery, and that indication that you saw is a viral load is over 1,000 at the time of delivery, IV AZT needs to be given to mother, whether her virus resistant or not, because it's really the wild type that crosses the placenta. And we want to continue those medications throughout the hospitalization and the discharge. I've had some mothers come back and say, "Oh, I was told to stop my meds and that you would talk to me about it." And I just, don't do that. You've got to take those meds because we don't want viral rebound. And plus, what if that individual was co-infected with hepatitis B? And they stop those meds. Well, our HIV meds, um, TAF-FTC or TDF-FTC is a great treatment for Hep B, and suddenly you're coming off of those, you're getting viral rebound. So we want to continue these meds. We talked about avoiding breastfeeding. We have alternative feedings. Avoid pre-mastication of food. We don't want transmission of HIV through that. There's been a couple of cases nationally that talk about this. And know who to call. Um, there are folks available through the National Clinician Consultation Center that I think is so important that are available to help discuss these cases. Let's skip this case due to time because I do want to answer some questions. Basically, what we want to really talk about here is we want to make sure, and we've talked about this, that mother gets Tdap with every pregnancy. So let's go ahead and just skip that due to time. But the other thing to keep in mind, the two things that I've already talked about is don't make the assumption that somebody else is giving the vaccines. Talk to that patient, have that team approach. We still have some providers that believe, oh, you have HIV, it's dangerous to vaccinate you. No, that is not true. Now, several years ago, we talked about live attenuated vaccines and not to give it to individuals with HIV, but that's no longer true. We want to know what someone's CD4 count is, and we want to have those discussions. So with pregnancy, there are times where we do have some vaccines that are contraindicated. The live attenuated influenza vaccine, MMR, varicella, but we want to have the conversation, keep it on the radar. So after they deliver, we want to go ahead and vaccinate. For the HIV world, if their viral load's less than 200, yes, we want to avoid live attenuated vaccines due to risk of them acquiring disease. But if they're above 200, um, we want to vaccinate folks. We don't want to miss that opportunity. And those of us in the Southeast, we've seen a hepatitis A epidemic going on for the last couple of years, and a lot of it went back to poor screening and poor vaccination. So we want to think about that and think about what you're doing in your institution and making sure that we're completing the vaccination series. And I'll just kind of end this with just a reminder that HIPLA-B has been out for a while. So we know with data getting through the Hep B vaccine 3-shot series, we really drop with each step the percentage of folks completing the vaccine series. And with a 2-shot series, at least 30 days apart, we can see that it's very comparable. And if you look at Injurex, as people even age, if you use HIPLA-SAV, the immune response is still above 90%, despite individuals over the age of 60. So hopefully with a 2-shot series, we'll be able to vaccinate folks with hepatitis B. So I want to thank everybody. Again, if you're interested in it, we have a 4-page handout that really gives the highlights of everything I just discussed. Please email me, and I'll get that to you once it's approved, hopefully in the next couple of weeks. And we continue to update that as the guidelines change. So I want to thank everybody for their time. And if we have any questions, I'm going to stop sharing so I can actually see the Q&A. And Damon or Evan, if there's any questions, just let me know.
All righty. Thank you so much, Dr. Felzine, and we really appreciate that. That was a lot of great information. We do have a few comments in the chat box. I'll see most of them are asking about the slides. The slides will be made available. Just a second. Let's see here if we have any in the Q&A box. And if not, if you guys are interested, I'll open up the panel, the change the controls so that you guys can speak.
And even when you get the slides, I mean, my last slide has my email address. I mean, please feel free to send me questions as they come up. I'm happy to discuss cases, systems, flows, how we have kind of gotten into some rural facilities to do some education, and then there can be some challenges with that. So please reach out, and we're happy to have those discussions.
You saw him, he can spray that mask. Told him that he could even get that spray, because he's spraying everybody and every little thing.
Somebody's kids are at home.
Right.
Wonderful. Well, either I hit everything and everyone is happy as a clam, or they need to get on to their next stop because it's 2 o'clock. But I can't stress enough. Please reach out to Damon, myself. Um, we're happy to answer questions offline. Do some follow up. We're happy to get you that handout that we've developed to hit those highlights, and really to have these discussions, or even if your facility has said, hey, I'd like that presentation at my facility, I think that would be good. Let us know. We're happy to set that up and have those discussions. So thank you so much.
As Dr. Felding said, we thank you for your time. We do see that it is a little past 2, but we don't see any questions in the question and answer box. So I think you did a pretty great job, Dr. Felding. Guys, please copy and paste the evaluation link, which can be found in the chat box, as well as some upcoming events that we have that are on the way. So we thank you for your time and your patience and just joining us on today. Again, until next time, thank you guys.
Thank you. Stay safe, everybody.